Thank you very much. Now, as the last presentation, we invite Professor Erik Stroes from the chair of the Department of Vascular Medicine at the Academic Medical Center in Amsterdam, who will teach us about the interplay between lipids and inflammation and ask the question if this could be an opportunity for targeting. Thank you for your presence and your talk.
Wow, this makes it very difficult, right? There's so many pathways, and if you see all this, it's difficult to translate back to what we do every day. So what I will do is actually try to simplify and show you that even in this complex system, there is some very elegant early translational work that we can use in daily practice. So I will show you a little about the interplay between LDL and cellular inflammation, not going into the subphenotypes. Then show you some strategies how to reduce cellular inflammation where we have some experience, and finally future directions. So lipids, you heard that basically if we make it simple, atherosclerosis is an interplay between lipids and cellular inflammation. We know that if we lower the lipids, we have profound beneficial effect, but what do we know about directly addressing cellular inflammation in atherosclerotic disease? That's very little. So if we actually look here, we can study in humans in vivo the inflammation of the plaque by basically simply using fluorodeoxyglucose and assessing the metabolic activity of the plaque, which very elegantly draws a parallel to the inflammatory activity of the plaque. So this is one thing we can actually use. And it works if we, for instance, look in patients with profoundly elevated LDL cholesterol levels, so it's a pure LDL disease. You can see here that in the FH patients, there's a significant increased metabolic activity in atherosclerotic lesions. So high LDL always leads to cellular inflammatory activity in the atherosclerotic lesions, which after the former lecture is pretty obvious. So what about the active influx? Well, to actually understand how the active influx is, we already 2 years ago, we labeled the polymorph blood, the white blood cells. White blood cell was with technetium, and if you reinfuse that into patients, it was quite interesting to actually see that patients with advanced atherosclerotic lesions, here in the upper part, you can see that within hours, within 6 hours, you see accumulation of these white blood cells in the advanced plaques. So it's a very dynamic process, and it's not static, a number of cells in the plaque. No, it's a very active accumulation which occurs only in atherosclerosis. So what are the levels that we can consider intervening in this inflammatory cell activation which contribute to atherosclerosis progression? Basically, I will show you 3 different levels, which is more or less not completely the same what you heard in the former talk. The first is obviously the simplest. That's within the atherosclerotic lesion. Now, for reasons of simplicity, I will skip T cells because basically they're too difficult for me. It's very difficult to interfere at T cell level, so let's just focus at monocytes, macrophages. These are crucial in all the steps we heard in OXLDL. Well, we know that the plaque, by the work of a lot of people here, we know that plaques are leaky, so they have these immature vasa vasorum due to hypoxia, so they leak the nanoparticles. And DJ already showed you very elegantly that if you then take out the plaque of these patients with peripheral artery disease and you isolate the cells from these plaques, focusing at monocytes and macrophages, there you can see that if you don't infuse saline, you can see the blue staining for the nuclei of macrophages. You can see the CD68 staining, but you don't see PEGylation, which is in the infused nanoparticle. And if you actually look at the triple staining here after PEGylated liposome infusion, you can see CD68 for the macrophage, the nucleus staining, and you can see the staining of PEGylation. So it actually shows that there is penetration of systemically infused nanoparticles, but we don't know how much. So to what extent we can successfully deliver sufficient drug to these cells is not quite clear yet. So is there a better particle to do so? because nanoparticles like liposomes are between 80 to 100 nanometers. Should we go smaller to increase leakage and penetration into the plaques? Well, work by Willem Mulder actually shows that if you compare here liposomes of approximately 80 nanometers with reconstituted HDL particles, which are approximately 13 to 15 nanometers, you can see here in the pictures that obviously liposomes, there's a liver targeting in both of them, but here you can see in the atherosclerotic wall, there's not that much liposomal accumulation, whereas if you look at the much smaller HDL particles, there's more uptake into the atheroma and the arterial tree, which makes sense. If you have a smaller particle, they more readily penetrate into the leaky vessels in the atherosclerotic tissue. Is this feasible in humans? Well, to evaluate this, we actually took a commercially available drug, which is Serenus 001 by the French company Serenus. You all know, obviously. So, and if you look at this compound, it's reconstituted ApoA1 with phospholipids, giving you a very tiny HDL-like particle. And if you label this with zirconium, you infuse it into patients, you can actually see whether HDL penetrates these plaques in humans. And if you do so in patients with severe carotid artery disease with stenoses of 30% and above, you can appreciate that there is an increased signal. So that implies that actually there is some zirconium signal in the atherosclerotic plaques. But more interestingly, if you compare the plaque regions to the non-plaque regions, creating endogenous controls, you can see that the accumulation is particularly restricted to the plaque regions and not to the non-plaque regions. And very preliminary, there appears to be somewhat of a correlation with contrast leakage into the plaques. So this implies that this holds a promise for future therapeutic strategies, and Willem Mulder presented 2 days earlier already work that at least in animals it works, now we should show in humans. That was level 1, the artery wall. We're getting there. We're actually achieving local delivery. What about a second compartment where we spend much less attention? That's the plasma. If you look in the plasma, for instance, again in hyperlipidemic patients, we can actually see that if you, and it's very difficult from here, but you can see that all the chemokine receptors, there is an upregulation, an activation of circulating cells already in plasma. So that already differentiates. And actually to show you, if you take cells from these patients, you can see this is for normolipidemic, and if you cut these cells microscopically open, there's very little green staining of lipids. And if you do the same in hypercholesterolemic subjects, look at this massive amount of lipids present in circulating monocytes. So this is not in the arterial wall, this is already in the plasma. So that relates to the activation of these cells. And if you then put these cells on a running, so this is a competition, right? Truly US-like. Here are the cells of the normal lipidemic controls, and here from the familial hypercholesterolemia subjects. And if you apply MCP1, so that's the attractive, like the dog runs, where you put the rabbit in front. So these cells from hyperlipidemic patients, they run towards the MCP1, and normal cholesterolemic cells actually don't. And if you then do individual quantification of these cells, you can see that in healthy controls, they go all over the place. They even run the other way. So they are not that much attracted by MCP1. But these hypercholesterolemic cells, they are very focused towards chemotaxis, which actually promotes adhesion and transmigration into the atherosclerotic lesions. And if you quantify that, it's obviously highly statistically significant that there's a proneness toward adhesion and invading of atheroma. Are there already trials addressing this? Yet not nanotherapy trials, but there are some trials like the CANTOS trial, IL-1 beta inhibition, and the CERT trial, MTX inhibition. So the early trials are addressing to reduce this inflammatory phenotype of circulating white blood cells. And we will know most likely within 1 year. Now, very briefly, the third component. Because we've heard about atherosclerotic tissue, we've heard about cells. Well, where do these cells come from? The bone marrow. So why are atherosclerotic researchers not interested in bone marrow? And they start looking at the hematologist. as soon as the word bone marrow is mentioned. Well, that is going to change, because the bone marrow is actually the beginning of where all atherosclerotic disease gives its first stimulus towards these pro-inflammatory state. Now, just a tantalizer. I like Borg Nordesgaard. He's one of the biggest epidemiologists in Europe, in Denmark. So what Borg did in his Copenhagen heart study, everyone in Denmark is traced. So you can see that if you look, for instance, at some lipid markers, that whenever your lipids increase, your circulating monocytes increase. Interesting. So apparently, lipids do something on your circulating white blood cells, including monocytes. And if you look at these data by Fleur van der Valk, after 1 year, you can see that after 1 year, there's not only in atherosclerotic disease, there's an increased signal in the carotid artery, but also in the spleen and the bone marrow. So cardiovascular patients also have abnormalities within their bone marrow activity. And even more interestingly, if you draw bone marrow from these patients, you can see that the colony-forming units is increased if you actually add a little bit of oxidized or modified LDL. So it's directly cholesterol altering the behavior of the precursor cells in the bone marrow. And actually, they not only activate colony-forming units, but there's also a myeloid skewage with increased CCR2 upregulation at their level, which, by the way, reacts to MCP1. So the new model actually shows that lipids also induce myeloid skewage at the level of the bone marrow, activated circulating cells in the plasma, and eventually then going into atherosclerotic tissue. Is that relevant? Well, it might be, because actually data from Boston, from Ahmed Tawakkol, show that there is in post-ACS patients, there's an increased signal in the atherosclerotic tissue, but also in the bone marrow and the spleen. And if you then look at the prognosis, it's the patients with the increased bone marrow metabolic activity who have worse outcome. And the same holds true for the spleen. So this is actually one of the predictors, an inappropriate hyperactive immune system already at the level of the bone marrow, which influences an adverse outcome of atherosclerotic disease. So to summarize, well, we can use this to actually do readout, and we can target arterial and bone marrow, so imaging is going to be pivotally important, but I think you already know that. So to summarize as a take-home message, first, disproportionate immune cell activation promotes plaque growth, destabilization, and cardiovascular events. There's a lot of data there. Second, hyperlipidemia induces immune cell activation at various levels in the plaque, in the plasma, but also already in the bone marrow. Third, targeted nano-delivery system holds a promise, particularly for artery wall targeting, which DJ already showed you, where we're beginningly successful. But what we're not doing yet is bone marrow targeting, because actually if we directly target the bone marrow, that could actually take away the initiating stimulus for these hyperactive cells. And lies the PEG-liposomes liposomes and HDL particles both successfully target the atherosclerotic wall, but obviously we should learn more about what drugs to actually package in these particles. Thank you for your attention, and particularly thank you to NanoAthero, which is a tremendous group and allows a lot of fantastic research. Thank you.